A little technical difficulty today, so we're going to go ahead and jump right in. And hopefully folks can hear. Great. Okay, awesome. Well, we are really excited. This is our third virtual learning circle of 2022. So we've kicked it off with two really great conversations, and I think today is going to be no different. So I'm excited to introduce the speakers that we have today. But first, I want to thank the awesome team that is really behind all of the work that takes place from month to month. So special thanks to Suzanne Morris, who's not with us today, but has done a great job of bringing the most awesome speakers to us. Marcus Sabs and Gabby Durden, who are helping with logistics. So thank you all for your continued dedication and work with the virtual learning circles. And with that, I am excited about today's conversation because a big part of the work that I am doing through Grantmakers is helping to figure out how we coordinate all of the different components that really will make up the most impactful system for early childhood in our region. And that means that we bring together those that work in community service, policy, philanthropy, and research. And one of the things that has really continued to come up is that we have incredibly, amounts of folks that are working on collaboration and thinking about how to support health outcomes, how to support education outcomes, how to make sure that we are informed in how we provide investments for young children. But then there's also this question of what's the true frame around it. And I think that what is most exciting about the work that is being done at the Center for the Study of Social Policy is that you all have thought about a framework that's emerging, and it's called Early Relational Health. And I am very excited to learn more about your approach and what it really means to operate across systems, focusing on positive relationships and how positive relationships really do drive better outcomes for children. When caregivers are cared for and families have what they need, they can then give the best to their children. And so I think that is what has made me so excited about what you all are going to talk about today. And with that, I'd like to introduce both of our speakers. We are so lucky to have national experts join us in Allegheny County, so thank you all for coming. I'd like to introduce Dr. Willis first. David is the Senior Fellow at the Center for Study of Social Policy at it's a national and nonprofit policy organization that connects community action, public system reform, policy change to create a fair and just society in which all children and families thrive. At CSSP, David focuses on the intersection of child health, the broader community-based early childhood systems, and he's launched a national initiative on early relational health. Prior to him working with CSSP, he was working at the Perigee Fund, and he was the executive director there, which really helped the fund to focus their work on the well-being of very young children. And I have a ton of respect for the work that you did at Perigee and have worked a lot with some of the folks there as well. And so it is tremendous to have you on this call today. And really the focus there has been on trauma and racism. And I think that that is a very important component of what it is that we're going to talk through today. So I cannot wait to dig in. I'd also like to introduce you to Callan O'Connor. Callan is the Senior Associate at the Center for Study of Social Policy, where she works to promote better outcomes for young children and their families with a focus on promoting the protective factors that children, families, and communities need to thrive. And this includes coordinating the Strengthening Families National Network of 35 states with CSSP's Strengthening Families Protective Factors Framework, which many of our participants may be familiar with that network and the framework there. She supports cities and counties in their efforts to better support early learning throughout their communities as a part of the Early Learning Nation. So with that, we appreciate you for joining us. We thank you for bringing your expertise here today. And I would like to just go ahead and turn it over to you and David. One of the pieces that's going to be a bit different for the audience today is that they really wanted a lot of participation from all of you. And so we are actually going to bring you into the conversation as it is taking place. So be prepared to become panelists in a few moments. And if you are able to come onto the video, we would love for you to see your faces. If not, no pressure. But with that, we want to go ahead and give Dr. Willis and Callan the floor.
Thanks so much, Robin. Good morning, everybody. It's very exciting to be with you all. And we're eager to share with you what our learning has been and our framework as we're moving to advance this paradigm shift of early relational health. And I'm going to pull up my slides as is tradition that we do. And I'm trying to select share of my slide set. Let's see if it comes up. Is that there now?
Yes, we can see it.
Good. And then I'll go into slide mode. So now we're good?
Mm-hmm.
All right. Well, great. We're really excited to share with you what we're moving in terms of our early relational health paradigm shift. And let me be very, very clear, and you all know this, a baby's future starts really early. And I, as a pediatrician, I'm compelled to think about human development from the very start, even prenatally. The hopes and the dreams and the experiences prenatally help shape what become a child's future. Then the relational context and then the context around young families matters in terms of building that. And that's been our life journey, my life journey. Yet let's set the context. We all know that children have been really, and families have been really struggling. This data from the Rapid EC project, which is a real-time survey of families of children 0 to 5 through Stanford with Phil Fisher and others, have been following the experience of families over this last 3 years, especially during COVID. And we know that families, if you look at the numbers, and this is a representative sample of young families with children 0 to 5, they've been struggling with stress. And children's well-being over time, likewise, has been strikingly challenging, with up to even 50% of children describing having externalizing trouble. And we know, likewise, that material hardship plays a significant role in terms of children's sense of well-being. And remember, during that period during COVID, when we had the child tax credit that was available to all families, we saw dramatic shifts in a family's sense of stress that was measurable by family self-report. Until then, that later period around November, December of 2021, when that child tax credit was removed, an uptick then of that sense of family distress. And we know that with more hardship in families comes more distress in young children. This is the context, and now we all know that we have a children's mental health crisis at every level. And I ask the critical question of, why is that happening? And more importantly, how do we prevent it? Hence that sense of what are the strategies that become really important in strengthening the well-being of families to counter both the challenges of maternal well-being, material well-being, challenge the stress that families are experiencing that impact children, And then thinking about what drives, unfortunately, what becomes the regulation of emotional state challenges that become, shall we say, mental health crises down the way. Can we be intentional to drive and develop a strategy of strengthening the well-being of young families to counter these vulnerabilities? And I would say that our relational health frame is about that effort, harnessing the power of human connection. Human connection is critical for weathering adversity and to protect the youngest from harm. That science is clear. Even one relational pattern, one relational experience that's positive, strong, protective, nurturing, and warm is protective for the well-being development. The power of human relationship actually comes from simple, ordinary daily interactions. That's singing, reading, caretaking, moments of joy and interaction. Those meaningful moments in a young child's life are powerful in the sense of building well-being. And nobody has to be perfect in that agenda, but has to be intentional to build well-being efforts by those efforts. We all know the core story of child development, that the brain's built by early experience. We know that toxic stress and adverse experiences can derail childhood development. And we know that children develop in the environment of relationships. But can we harness that ever more intentionally to strengthen the environment of relationships, to build well-being? And everything we're seeing pushes that the relational experience builds health, development, and well-being. We've defined early relational health as that state of emotional well-being that grows from the positive emotional connection between babies, toddlers, and their parents or caregivers as they experience strong, positive, and nurturing relationships with each other. This may be a new term, early relational health, but it's actually not a new concept. It's built upon the research fields of child development, infant mental health, neurodevelopment. It's been well known, but we're calling out that those relational drivers matter. They build health, development, and early learning, and maybe the most significant element of building future well-being comes out of those relational contexts. And we also know that foundational relationships shape the well-being not only of the child, but also the caregiver. There's increasing evidence that that two-way relational experience affects two-generational health, the well-being of the caregiver and the child in that moment, and impacts over a long time. And thereby, the more we focus on the contexts around the relationship for children and caregivers, now and into the future, makes a difference. All families hope for the well-being of their children, but unfortunately, the context can disrupt the well-being, be that poverty, racism, the challenges of isolation, or the challenges of demoralization or worse, can disrupt what the hopes and the dreams of every family. So the context around the family clearly matters. What does it look like? Relational health is observable. Let's look real quickly at this little dyadic experience and think about what you're witnessing. In the blink of an eye, one's witnessing, experiencing a moment in this dyadic, joyful moment between them. Eye contact, affect, turn-taking, mutual vocalizations. One can see in an instant between them the relational experience. I would suggest that those are elements of what we call relational health. It's observable, it's increasingly measurable, and it's meaningful. And the brain and development of that next generation occurs by these meaningful moments, not continuously, but moments of positive, strong, and nurturing relational experiences is what develops the next generation's health, development, and well-being. And it's developmental and sequential. It's not just one moment. It's those moments of interaction over time. That relational pattern can be witnessed in the early developmental patterns. So as we speak about developmental milestones, we can also speak about relational health developmental milestones. One can see that positive interactive experience, that responsiveness, the positive enjoyment. But one can also begin to see the patterns of interaction that include the mutual initiation between one another, the imitation processes in their interactive space, and then the shared play and interactive patterns. Relational health has a developmental sequence that is observable, can be monitored, can be supported, and can be encouraged. The science is compelling. If one shifts from looking at individual child development to the patterns of synchrony, the synchrony of behavior, the synchrony of the physiology of heart rate coupling and interaction, the synchrony of endocrine development systems, the synchrony even in brain systems that oscillate together in that eye contact interaction. There's actually a dyadic neurodevelopmental pattern, and the science is increasingly demonstrating that that's where developmental patterns of building health and well-being occur. This is also the pattern where the stress regulation system, the emotional regulation systems, and the attention system and the development of cooperation capacities are built in that dyadic neurodevelopmental pattern that occurs in those meaningful moments of human development. It's just incredibly compelling. We also know there's a lot of work already going on to promote early relational health, not only in the health system, but in the community. One knows that the health system, pediatrics, and family practice, primary care systems are increasingly focused on development and well-being. Increasingly, we're seeing activities where a team-based care model in the medical home, where there are actually members in the medical practice that are whose role is to strengthen relationships, to attend to family need, and to coordinate with communities as building the health, such examples as the Healthy Steps model or the Dulce model, or those efforts where there are community health workers linked within the medical home become really important as a team-based care model around the relational well-being of a family. We're starting to have measurement and promotion efforts within the medical home. We actually can begin to call out a relational health workforce that's building beyond just the medical home itself, but one could consider home visitors being focused on relational health with families. Community health workers can partner with families, and for those communities that are building out doulas and the doula supports and the perinatal supports, those are relational health supporting efforts that are really meaningful. And our work at CSSP is partnering with those communities likewise to help strengthen the relational supports around young families. Also, the work that are deeply place-based, and I know Allegheny is very interested in how one could begin to organize a community response that helps support the well-being of families, that by an all-in strategy between health system, community, and formal and informal systems that build relational health effort, those opportunities likewise are really growing, and we at the center and our coordinating hub at CSSP are working to harness, to learn, and to promote that kind of broader strategy. We're also building upon acknowledgement that this is a paradigm shift. The early relational health movement has captivated the interest of the American Academy of Pediatrics, and just last year they documented a policy statement to prevent toxic stress and promoting well-being by partnering with families and communities to promote relational health. And they call out that this is actually a paradigm shift in child health care, where we can reprioritize clinical activities. We have to rewrite the way we think about research and focus dyadically, and of course, focus on our collective advocacy, all focusing on that dyadic relational health promotion effort to build future health, development, and well-being, to tackle the challenges in front of us of the loss of well-being, the forces of racism, poverty, and the like that disrupt the well-being of families, and also the effort to try to counter the mental health epidemic that's in front of us by upstream effort to strengthen the natural developmental processes that can be brought into place. We've built a partnership with our Reach Out and Read colleagues. Our Reach Out and Read National is now partnering with 4 states in terms of helping the Reach Out and Read network of pediatricians, which is vast. Almost 30,000 pediatricians are Reach Out and Read trained, and now they've begun a next chapter agenda to bring early relational health into the partnership and discussions with families at the first encounters. So that effort of strengthening families' abilities around book sharing and book reading to be able to promote well-being is the new wave activity as representative of that paradigm shift in pediatrics. Pediatricians in their offices, when they have encounters with families, are beginning to talk about the criticalness of the well-being of relational health that can happen in those meaningful moments of interaction, but in those meaningful moments of shared reading. So that sense of linking early relational health and as foundational for later literacy is now moving forward likewise across the sectors. We've been learning that focusing on positive emotional connection between babies, toddlers, and their caregivers is foundational to early relational health. And we're learning also that one can actually see the elements of relational health, as we did with that first little video. We could see the domains of relational health that has been called within what's called the WEX lens, which is a tool that was developed at Columbia, the WEX emotional connection scale. But we can actually begin to see the patterns of relational health, shall we say, the vital signs of relational health by observation, noting the domains of mutual attraction, vocal communication, facial expressiveness, or sensitivity reciprocity, and what's observable behaviorally and what's observable in the emotional state. Just as we did in that brief video, we've learned that we are able to teach not only pediatricians, but other family-facing or providers the elements of relational health in a very short time. These elements can be taught. More importantly, it allows people that work with families to begin to help support families in those key elements themselves, calling attention to when they're visible, the promotion effort, the watching, the observing, the listening, and communicating with families around supporting that relational health is the movement that's building. And we're developing promotion tools that help that sense of watching, observing, and listening initiative, be that video feedback with families, as is happening within 503 baby clinics in Michigan, or that sense of building conversations with families, as is called in the model, early relational health conversations, having actual dialogue with families about their hopes and dreams and histories of those meaningful moments of relationships, moving not about screening and judgment, but meaning about promoting the health and well-being, and the strength-based assets that all families actually have in the hopes and the dreams for their families moving forward. We've been fortunate with our work at CSSP to build out a messaging strategy, partnering with families, with our team of collaborators, and building actually out the core story of early relational health. And then we build a messaging guide. Here is the website for that effort. And we encourage you to take a look at what we've created that are meaningful for your communities, for yourselves, across sectors. We're very mindful that the relational health work is a movement. And it's a movement of partnering deeply with communities and with families. Messaging really matters about the strength-based stuff of them. And that core story of early relational health is a part of our work that's built on the Strengthening Families and Protective Families framework. We recognize the criticalness of parental resiliency, social connections, parents' knowledge of child development, and of course, those concrete supports in times of need. All of that helps promote those social emotional competencies. And we will say that the early relational health framework is a part of the Strengthening Families and Protective Factor framework that we all know about. And it calls out too, that it's not just about relationships, but it's about the experiences in those supportive and resilient communities that surround young families. So one cannot talk about early relational health without simultaneously talking about the resiliency of the communities themselves that help support young families, recognizing, of course, the many forces that unfortunately structurally disrupt the hopes and the dreams of relational health well-being of all families, and hence the advocacy elements that we have in terms of countering the structural barriers is a critical part of our relational health movement. It also recognizes that we're moving past that sense of focusing on adversity, but actually focusing on the building blocks of health outcomes by positive experiences, moving from ACEs to hope and resiliency, building upon the work that Bob Sage's been doing about health outcomes of positive experience, the HOPE Network, in terms of, again, building on relationships, safe communities, social connection, and emotional growth are all a part of the work. And a system building effort around all of this means that one cannot have just one program to build a relational health, but this is really a community strategy, aligning all of the various supports around young families, both formal and informal health system, to public health, to community, to family support, and to neighborhoods, to build a thriving context around which then next generation can build. And we're learning more and more that one builds, when one creates a multiple element strategy in a community, partnering with formal and informal systems in support of the next generation of family well-being, much like the Harlem Children's Zone, baby colleges, and conveyor belt, that activity now that surrounds cohorts of babies and families with supports educationally, a support of formal and informal caregivers, the support of programs that are in service of supporting well-being of families collaboratively, and then measuring and monitoring change over time, sort of the new opportunity of building place-based agendas towards building future well-being. Harnessed, of course, around that sense of a relational health workforce. The health system is a platform that touches all families, but then building out those other supports that can be available around, be that community health workers, doulas, family home visitors, family navigators, and building that sense of that connection as a social determinant of health. No family should have a sense of being isolated or lonely. All families need that sense of positive nurturing and support efforts to the well-being of their next generation children. And I like to say, you know, every year a new baby's born, every day rather, a new baby's born with a future that they either realize by the positive nurturing and social experiences around them, or they lose by vulnerabilities of stress, isolation, and not enough positivity. So it's an important opportunity. We're also learning the criticalness of partnering with families. We learned some years ago that families have to have a sense of trusted relationships with the systems that care for them. And we know there are many barriers that have been built where families don't feel well heard, don't feel well supported, or worse, feel judged, feel marginalized, or feel distrusted. And all of our work is focused around the criticalness of partnering with families to their well-being, and those moments of interaction with families, with any provider, has to be attentive to the strength and the well-being that families have inherently. Let me describe it.
It's so interesting that part of when you were just speaking, what I was hearing was coming to it around quality, but separating that quality from the quality of quality improvement. And so when I think about that, the two things that were going through my head were meaningfulness and mindfulness. So meaningful engagement with the family, with the parent, and with the child when they are in that appointment. And that engagement doesn't have to be for 15 minutes. Meaningful engagement can happen in small, minute pieces. And it can send a specific message to the parent and to the child about your level of caring. I think that's that empathy coming through, and that compassion coming through when you're doing your care, but also the mindfulness piece. I do think that when we think about things like implicit bias and David, I hear you every time you speak talk about how pediatricians want to show up and how they want to do their work. And for me, understanding the medical system and how the healthcare system works, that does mean taking on the personal accountability for being anti-racist and working on yourself individually as a service provider so that when you're in those moments, you are mindful and you are coming from a very different place. And especially because of the lack of time and how rushed doctors are and all of those things. I think the meaningfulness and the mindfulness together with that quality can make all the difference in that appointment that is always too short and never long enough.
Can I come to? So our work with the health system is focused intentionally on an anti-racist effort around helping the next generation of pediatricians partner with families in recognizing their strength, and also helping physicians recognize their implicit bias, but also their sense of their own mindfulness of partnering with families in new and meaningful ways. The families actually welcome. That's a journey. One would say it's a similar journey then for the other family-facing organizations that likewise are participating and partnering with families over time. I have two more points, and then Kaylin, I'll turn it to you. I want you to think about development as being likewise a process that has deep knowledge and strength from the parenting process itself.
I actually believe that children develop parents and a bunch of parents develop children. And any of us that have had kids know that that journey is a path. I mean, we're on a journey with them and they pull from us what they need. And we have to be responsive and reactive, and we contribute a bit. That's, and so I absolutely believe in that mindset that it's a journey together with their child. The second thing I would add is, I also think that the wisdom that goes generationally also is a part of that journey, the wisdom of many. And no parent is perfect, nor do they need to be. And no one parent is responsible for the healthy future development of their child, because it's far more complex than that. But the journey of the multiple relationships are a part of assuring well-being. So that's why culture, that's why I think networks of people surrounding young families is a part of the resiliency strategy that captures healing and comfort and optimal growth and development. That's how I think cultures have evolved to create who we all are now. It was not one little dyadic experience, it was the collective wisdom, and that was brought to the next generation, either directly or indirectly. And there's a lot of indirect human development that happens when we provide the opportunities for children to grow and thrive from the people that are around.
So that's all the work we're capturing at our coordinating hub at CSSP. And we built a strong series, a strong group of partners and collaborators, as well as champions, and looking at how we can advance this paradigm shift and all that's knowing and the wisdom that's been built, and then the partnership with families that really helps us grow in terms of moving this agenda forward. We have a number of priorities that we've established, not only where parent leadership is key to our work around equity, and we have created a parent leadership council that basically guides and partners in all things that we do in terms of planning. We believe deeply in place-based work. We are making available resources for communities and providers. We're working on multi-sector workforce, not only health system, but doula workforce, and also community health worker workforce. We're developing training around community health worker, around early relational health work. We have a research network that's building. We are advancing some policy work, and then we're working deeply on messaging. And this is all coming forward as a collective impact agenda with our various teams of people working around this movement making work. And so the relational health work is about advancing a framework, dyadic and two-generationally, bi-directional perspective in child development, foundational to equity, resiliency, and recovery, has impacts on health, early learning, and social emotional well-being. It's all science-based, strength-based, but it recognizes cultural variability in parenting, but sees early relational health as a universal effort. And our activity is not a one program, but an all-in approach. And it's not about teaching parenting but supporting the strength and the resiliency and the hopes of all families, hence that paradigm shift of our activity. And you can see more of our efforts at our coordinating hub. We are actually rebranding our work in the first of the year with a brand new website that will be coming forth, so stay tuned. And if you want to follow us along, join us with our newsletter that comes out monthly. It helps people keep track of the movement and the activities that are going forth. Within all of that work, as we talked about moving into community-based efforts, we've looked at how can we help strengthen communities that are very interested moving forward in this relational health movement. So Kaylin, can I turn to you? And I can continue to run the slides if you wish. So if you want to come from here, will that work for you?
Yes, that sounds good if you've got it all in there.
Great.
Thank you. That's always a great overview, and I appreciate seeing the videos and little clips. As much as I work on this topic all the time, it's still always heartwarming and a good reminder to see those connections, see early relational health in action. So I'm going to talk about a community mapping tool that we created in partnership with some members of our EC Link network. That's the Early Childhood Learning and Innovation Network for Communities. That's a network of 17 communities across the country. We actually worked with folks from, I think, 6 of those communities and a few other partners that we knew were doing great place-based early relational health work to develop this community mapping tool. So let's go into the next slide. Just to look a little bit at why a community would want to use this and why we developed it. We know that, as David just explained so well, early relational health can be promoted across so many different sectors that touch the lives of children and families. It's not about implementing a program in one place or training one set of providers to do something differently. And so we really want to promote this as a cross-community, looking at everywhere that children and families are interacting and how we can promote early relational health in those various settings and interactions. So when we look across the community, that allows us to identify strengths and areas for growth. It allows us to recognize there's some innovations or strategies that we could say, oh, that's working really well here. We could do that over here, or we could expand that. And when I say it's working in one place and not another, that could be geographical. It's working in a neighborhood and we could move it to other neighborhoods. It could be a sector that something's working really well in that would make sense to transfer into another sector. There are a lot of different ways that can happen. When we look across the community, we can ensure a variety of perspectives are heard. So for example, if you live and work in a neighborhood where things are working really well, and you just decide that things are great and you're doing early relational health in all the ways you should be, that's not a complete story, because someone who lives a few zip codes away might have a really different perspective, or who works with a population that lives in another part of the town or community that isn't served as well. And so again, that can be geographical, that can be demographic differences, that can be professional differences of who you're working with and talking to. And hopefully those variety of perspectives would also include parents who are in the thick of raising young children and are experiencing this themselves, to know what systems are working well and which ones are not really meeting their needs for promoting early relational health. Doing this kind of community mapping also helps anybody to understand how their own activities and role fits with the bigger picture. So that collective impact idea of understanding that we're all working towards the same goal and we all have different ways of contributing towards that. It can help you to leverage resources effectively. I don't really like to use the duplication word, because I know that oftentimes when we have duplication, it's for good reason, but I do think we can be more effective and efficient in how we leverage resources. So for example, you might do a community mapping process and find out there's somebody who's a really great trainer about this content, who's only working with early care and education providers right now. That trainer could also be training home visitors or community health workers or pediatricians or the people who work in the WIC office, right? Like there's a lot of different ways you could leverage a really good trainer once you look across the system and see what's going on. And then we are always pushing that you would use this information to build an action plan for next steps. So you're not just mapping to find out here's what's going on, you're mapping to find out what do we want to do next? What would make sense? Where are the gaps? Where are the great things we want to take into other sectors or other places? Who are the partners we want to leverage better? All of those things we're hoping you're taking into an action plan. So let's go to the next slide to see what this tool is actually all about. So this is a simple when we say tool, we mean it's a document. You can download it as a Word document so that you can actually type into it, or we have a PDF of it on our website. It's designed to be completed by a group of leaders and stakeholders so that you assess what's currently happening in the community that's promoting early relational health and identify action steps to improve upon that. So let's go to the next slide. There are 3 parts to it. The first part is the mapping. And there are actually within this mapping, first there's by sector, which is what you see the image of. So you really say for the early care and education sector, and here's kind of what we mean by that. What early relational health supporting interactions and activities are happening in this area? Who's being reached? And what are the gaps and opportunities in this area? So when you talk about who's being reached, you might say this is working really well around this particular center that serves, roughly the area around it. But we don't see families that live in this neighborhood having access to a program like that. So that goes into the gaps and opportunities column. And when we say what ERH supporting interactions and activities are happening here, it could be, we have this evidence-based program that's being implemented in these sites, but it could also be there's this group of home visitors who have an informal group that meets for coffee every month, and they tend to talk about these great resources and the things they're sharing with their families. And we could formalize that or replicate that, or bring early relational health content more to that. So it could be formal, informal. And the sectors that are included there for the mapping are the formal sectors we think of, but we also include informal supports. We also include the child welfare system, which is always kind of arguable whether we want to include that in an early childhood system, because ideally the families we're working with would not be touching the child welfare system. But we know that they are. We know that young children are overrepresented in the early childhood or in the child welfare system. And so we didn't put it in there to call out that oftentimes their work is not promoting early relational health, but to create an opportunity to identify things that are working well and to include it as a potential action area to improve practice. Then there's a section, stay on this slide for a while. I don't have images of each of these pieces, but after you go sector by sector, there's a place to highlight cross-sector efforts. So this group, other groups that are meeting that are focusing on early childhood and perhaps on early relational health explicitly, or infant mental health, or other topics that are closely related, you would highlight there. And that could mean, there's an annual conference that focuses on early childhood that should be part of our thinking about this. There's a cross-sector group that meets for this or that. And then some reflection questions about what we're doing well, what we might want to do differently. So then we go to part 2, which is on the next slide. In this, you're really looking at how well your community is aligning to what we call the elements of a family-centered community health system. And it looks like the spacing got a little off on the side here, so I don't know if you can read all of them, but it goes through these 6 elements. We have a paper about family-centered community health systems that explains these all in detail. But the rating tool just allows you to look at what this section, what this element is. So intensive, coordinated, comprehensive strategies. And you can see the longer name there on the image, these strategies that for all infants, toddlers, and their families that support building foundational relationships for improved life course outcomes. Some examples of what that might look like in the community, and then how strong this element is in your community. You might say, oh, we're at about a 3 on this, and put some notes about why you think that. There's these 6 elements, and then there's a rating of how well these different elements are connected to each other and talking to each other. So this is, in addition to the mapping, it's another way to think about what's happening in the community. I will say you could choose to do one or both of these. You don't necessarily have to do both. We encourage you to use both, but if you just want to do the mapping and not get into the family-centered community health system, or if you're all in on the family-centered community health system and you don't want to do the other mapping, that might be a little trickier, because we do have reference in here to be like the cross-sector initiatives you found in part 1B would reflect your strength for this first element, for example. So that is a separate section. The paper about a family-centered community health system is available on our website if you wanted to really dig in on that. And then part 3 on the next slide is about action planning. And so this is just a really simple template for action planning. You might have an existing action plan that you want to add to and not do a new thing here. Or there might be some community level action plan that you're going to add to. But if you're starting from scratch, this kind of goes through the basics that you need to create an action plan. So you're saying what you're going to do, who's responsible for it, giving yourself a deadline, because I don't know about you all, but things don't get done on my to-do list if they don't have a deadline. The budget or other resources needed for it, and then what your indicators of success will be. So, so you're not just saying, we're going to do this thing that's sort of lofty. You're going to get a little more concrete about who's doing it, when, what it's going to cost, and whether you have what you need or you need to fundraise or whatever that might be. And then what's it going to look like if it's successful, so that you have some accountability to whether you've actually accomplished the things that you set out to do in your action plan. And I think I have one more slide. Oh, questions. That's what I thought. So we don't even necessarily need to leave this up, but I think we are ready to jump into discussion.
Yeah, I think this is great. Thank you, Callan, and thank you, Dr. Willis, for sharing so much information with us today. I think what I'd like to do is just spend a few minutes really digging into the tool a bit. You both had a lot of rich, information to share, but I think that what is going to be most important is that we've got a lot of partners, a lot of tables, a lot of investment that's already taking place in the prenatal to 8 space in our region, which is fantastic. But I think that as we think about how I'm at in different conversations, we're oftentimes trying to figure out how do we make all of this work together and not continue to create yet another table, yet another board, another, initiative, but really coming together. And I think that we have all of the special ingredients here in Allegheny County already. We've got the Department of Children's Initiatives. We've got Hello Baby, which is a phenomenal program that really focuses on comprehensive supports for families. And I think most of our practitioners and community leaders would say, we're doing this. That's the focus of our work. But the question is what makes this tool unique? And really, what would you have as advice for organizations or leaders that want to maybe engage with this approach to try to put together the puzzle pieces so that we're not all just kind of pieces on the table, but not really making a full picture?
I'll take that first. And then David, I think you'll probably want to jump in, but I would say that is why we have this tool, because everybody we're talking to in communities that are engaged in this work, and this wouldn't necessarily be true of every community across the country, but these are communities that we're already in contact with. We're saying like, yeah, this work is happening, but it's happening in pockets, or, the left hand doesn't know what the right hand is doing within our community, or we are aware of the inequities in who has access to these programs or who's getting this kind of support versus less relationally focused level of service. And so we want to look across the community, have that 30,000 foot view or maybe a 10,000 foot view that allows us to say, we can see what's happening across the map. We can look for opportunities to spread things, to better connect across things. And it's not that you need a new evidence-based program to drop into the mix. It's not that you need a new coordinating table if there is one. So as you do that mapping, you say, this group is already meeting. We're all actually here. Or, a lot of us who are participating in this mapping are part of that group. And we think this group could take this on. And so then it becomes a new agenda item for that group that we're going to be checking in on this. We're going to add action plans that are that group's responsibility to carry out. It's really the benefit of the tool. Our hope with the tool is that it helps you to maximize what is going on and grow what is going on. We are strength-based in everything we do. So we're always saying like, what's good, what's happening, do more of that, and find out who's not benefiting from that right now and make sure that they can benefit from it as well.
Yeah.
Because we always have that eye on the equity work, which no individual entity can take on equity at a community level, because each program is going to serve who they're serving, and they can try to be intentional and targeted about that, but it's still a patchwork. When you take a step back and look at that patchwork, you can see where some folks aren't being served as well or need additional services and opportunities.
Yeah, and so before Dr. Willis jumps in, that pushes me to ask another question. Who would you say, or what entity would be best positioned to lead the charge on applying a tool like this, to get it really from a concept to action?
I think that every county, every community is its own story as to what table has the strongest family voice contribution and participation that then touches systems. I think I'm at it to add to Kaylin's point of view, which is so strong. It's also essential that all of that our focus likewise be on the intentionality of focus relationally, then being very intentional about how do we create the trusted experiences such that families are telling us that these efforts are actually meaningful to them. And so any table that has strong family representation, family voice contribution, is really focused on the equity and trust building activity, strikes me as being the best place to try to center this effort, and then the other community programs as a part of that learning journey. We certainly know that there's a lot of work that has to be done to disrupt untrusted or racist structures and programs that have not heretofore been well engaged with families because they're not well trusted. We have many programs that we can offer, but families don't take up on them. And we have to find new ways in terms of partnering and engaging with families that are meaningful, and thereby tables where there are strong family voice and partnering, and then dialogue of how do we build more trusted environments and activities for families becomes a part of that agenda. I would also say there's always an urgency. Again, every day babies are born, and in 1 year their developmental capacities are built or not. So how do we have likewise tables that have that sense of intentionality and urgency and partnering with trusted allies in terms of movement making at the system level?
Yeah, I think that what has piqued my interest so much about this framework is that we all say that the work we do is centered on family voice, but I think what it seems like you all have really emphasized is this: not just one program needs to function and focus on families, but the system does. And so I'm curious to know, you had mentioned, Dr. Willis, in your portion of the presentation, that you work very closely with pediatricians and really helping them to understand how to function in a way that is responsive to all the needs of the families that they serve, and specifically thinking about what it means to be anti-racist. And one of the pieces that we have continued to see in our data, especially around maternal health in Allegheny County, is that there's tremendous amount of disparity, especially as it relates to Black maternal health. And so I'm curious to know, what does partnering look like and sound like there, and how could we promote or support, especially some of the funders that might be on the call today or might listen in on the recording later? They do a lot of funding around supporting Black maternal health, and what we continue to hear as a theme is that we've got to do something about the system. So I'm curious to know a little bit more about that particular approach that you've taken in the work, and how that really has fueled change in some of the communities that you've worked with.
Well, first, it's a work in progress. Two, it's hard work breaking barriers and privilege and historical structural barriers. So, I don't want to be Pollyanna about it. But one is, who are the champions in the health sector in Allegheny County that are eager to find new ways of partnering with families? That's the first. Who are your champions? Because you lean on them within the health sector. Number two, one cannot do any of this work without calling out poverty and the issues of poverty, and how poverty creates a disruptor to the well-being of all families. And the movement that we're seeing in some communities and around child tax credit or cash transfers or the like, it's absolutely disruptive to the structural forces that make the well-being of families and the maternal outcome well-being, as well as the early relational health outcomes problematic. Poverty is a huge driver of this work, and let's be very intentional. The health system knows that, and they can't do anything about that without, cultural and societal help. 3, I think in the health sector, the major transformation to become far more supportive to the well-being of families has to be a team-based care model. So one pediatrician and one family is not going to solve this problem, and it's not going to create those changes. Whereas those models that are moving to bring in community health workers into the medical home as part of a broadening team, like the Dulce model, or the Healthy Steps model, or innovations that build doula connections with the medical home, or the home visitor connecting point between the medical home and then the community. That intentionality of linking supports where the access point of the medical home touches to supporting families back out into the community. That's where the work is. So building team-based care models is really strongly also the effort. So 1, who are your champions that you can lean in on, that believe in this transformational agenda? 2, how do you build out team-based care models? And 3, if there's bold community intentionality around addressing anti-poverty intentionally, is the major strategies we're seeing that communities are trying to move forward on.
Absolutely. Thank you.
I was gonna jump right into community-based doulas too. I think there's so much, there's so many systems that are contributing to the challenges for maternal health. It just experience of discrimination on a daily basis is a stress on the body that we see reflected in those disparities in birth and well-being outcomes. And we can't tackle all of those all at once, but having a doula by your side who you do relate to and who has your back, I think can be really powerful. And so we're not going to achieve for people who are pregnant today, we're not going to get them all, a doctor who understands and who they relate to and immediately trust. But we could maybe get them, or most of them, get a doula who's by their side for that process while we work on changing other systems that are impacting that. And so that's the on-the-ground strategy that I'm most excited about. And if I had money to give, that's where I'd be giving it, is on that doula movement, and really making sure there are doulas who are from and of the communities that they're serving, who have trust and build a relationship quickly with pregnant people so that they can support them throughout that process.
Absolutely. And when we've done, convening of groups, that continues to come up as a big part of the solution. I think that in the last few minutes here, if there aren't any audience members that have some questions, put them in the chat, or you can jump up to be a panelist for a second. We certainly would welcome them. I think this was just a very baseline conversation that just kind of touched the surface on really what this work is really all about. We intend to invite you all back to work with us in person in Pittsburgh in February. And I think that it will be a great opportunity for us to really engage with the tool and dream and think about what it means to actively serve families in a very equitable way in Pittsburgh, and really put them at the center of our work as we continue to work really hard together. And certainly I think many, many people that do this work every day, we know that you are centering families there, but what this tool can do is really help to braid it all together in a way that perhaps we had not previously considered. So we appreciate you sharing this with us today. Oh, we've got one question here. Michelle's in the chat. You guys see it?
Kaylin, you want to answer that? Oops, can't hear you.
Sorry. We just developed the tool last year, so or within the last year. So we haven't had a lot of communities use it. We've had the communities that helped develop it have piloted it. And they found it really helpful for kind of grounding everyone on the same page for what they wanted. They have these groups that are kind of sprawling and they're investing in a lot of different strategies and not necessarily always seeing how they all fit together. And so they found the tool helpful in that way. I know that Boston used it and in the piloting process and did actually build an action plan through that, even though they were piloting it, they didn't have to do that part, but they found it useful and did decide to add some action plans to say, this is happening really well in some parts of Boston, or I think they were actually looking at the metro area. So they were looking at things that were working well in some areas that they wanted to try to replicate. And being more strategic in coordination of those things. But unfortunately, we haven't had that many people use it so far. We have this tendency at CSSP to just put tools out on our website, and people sometimes download them and run off and use them without telling us about it, which we encourage people to use it. But then I'm always like, I would love to know who's using it. So I'm not aware of a good, strong example other than those who piloted it.
I would only add, agree with that, and add Onondaga was one of our community. It actually used the mapping tool about a year and a half ago, and I think it helped seed their PSP investment strategy as they recognized that the health sector was really where they needed to work deepest. And thereby the mapping tool helped them begin to create the connecting point with the health system that had generated their PSP project around early relational health transformation. So it can serve opening conversations.
I'm also curious, I know we're a little off over
Yeah.
time, but I think you bring up a good point around the use of the tool and the opportunity for operationalizing it. And so when I think about what it means to be able to really do this work or to make this work happen, what do you think it would take? Do you think it takes an intentional facilitator? Is there funding that needs to be put in place so that people can really utilize this and make it come to life? Have you seen that in the communities that have taken advantage of it, like Boston and New York?
Kaylin, I'm going to have to jump off. My apologies, because I'm leading another committee meeting right now. So I'll look forward to further conversations. But Kaylin, I'll kick that question to you. Be well, all. Thanks so much.
Dr. Willis.
All right. Bye-bye.
Thanks, David. Yeah, I would say the communities that piloted it did not invest specifically in that process, but they had existing collective impact early childhood efforts that they were able to bring it to. So that base level investment of somebody's convening that group, somebody's bringing them together. In Boston, it's the United Way. In Onondaga County, it's an Early Childhood Alliance. In Washington, D.C., it's this Early Childhood Innovation Network. So there's different, different structures that were already in place. So if you didn't have that already, there might be some funding involved in just having somebody to facilitate it. I don't think you necessarily need an outside facilitator, but you do need somebody who's kind of driving the process, making sure, everybody's comments get compiled and shared and all that. And then, of course, if there is funding available, the action plan that comes out of this process would present opportunities to fund things. We are always trying to make things accessible to communities that don't have funding, might not have philanthropy at the table, and so they're trying to do things on a shoestring. And so we're often pointing out, this good thing is happening. It wouldn't cost that much to replicate it somewhere else. But if you have funding to work with, there's a whole world of possibilities of things that you could say, we're really going to ramp this up. We're really going to target, a particular zip code or set of zip codes, or we're going to go all in, or whatever approach you might want to take based on your action plan.
Absolutely. Well, that's very helpful. Thank you. Well, we are over time. We thank you for you providing so much information, and hopefully this is just the beginning of the conversation that we will deep dive into in February. Thank you.
Yes, thank you so much for having us. And we look forward to February coming to talk with you all some more.
Absolutely.
Thank you.